Good morning. My name is Dr. Efren Vicaldo, and I'll be lecturing on basics of cardiology. So let's start by discussing disorders of the cardiovascular system. And we are very familiar with the fact that history taking is very important. This is the richest source of information concerning the patient's illness. So general medical history includes personal past history, occupational history, nutritional history, as well as review of systems. The family history is very important because there are some genetic influences in the many forms of heart disease, and history of the risk factors for ischemic heart disease. We're familiar with the risk factors of hypertension, diabetes, smoking, and dyslipidemia. And these are important data we have to gather in the history, as well as the influence of activity on the patient's symptoms. What degree of exertion triggers, for instance, angina or palpitation or difficulty of breathing. Then we go into the manifestations of our disease, and this could be brought about by myocardial ischemia, disturbance of the contraction or relaxation of the myocardium, obstruction to blood flow, or abnormalities of cardiac rhythm or rate. So what are the cardinal symptoms of heart disease? Dyspnea is very prominent and common, and this is nothing but an uncomfortable awareness of breathing. If it were sudden an onset or sudden development of dyspnea, then these are the different entities that could be the reason for such as pulmonary embolism, pneumothorax, acute pulmonary edema, pneumonia, or some form of airway obstruction. If it were slowly progressive dyspnea, then this could be because of chronic congestive heart failure, obesity, pregnancy, bilateral pleural effusion. Now you may also have to distinguish between inspiratory or expiratory dyspnea. If it were inspiratory dyspnea, then it could be because of an upper airway obstruction. Otherwise, if it were expiratory, then lower airway obstruction. Orthopnea is nothing but dyspnea in the recumbent position. And this is commonly due to congestive heart failure, bronchial asthma, COPD, or bilateral diaphragmatic paralysis. The so-called PND, or paroxysmal nocturnal dyspnea, usually begins about 2 to 4 hours after the onset of sleep. This could be accompanied by cough, wheezing, or sweating. And this is often relieved by sitting on the side of the bed, and the characteristic disease entity of the heart is that of heart failure or LV dysfunction or LV failure. And this could be preceded by cough. Hypopnea is dyspnea that occurs only in a lateral decubitus position, right? This could be seen in patients with significant fluid in the chest, okay, such as in patients with significant pleural effusion. Platypnea is quite interesting form of dyspnea in that this is commonly seen in patients in upright position. The disease entities or abnormalities of the heart that could bring about this type of dyspnea is that of PFO or patent foraminovalle or patients with atrial septal defect. Okay. Next symptom is that of chest pain or discomfort. Levine sign is the clenching of the patient's fist. and putting it in his sternal area. This is characteristic of patients who suddenly develop angina or chest pain due to coronary artery disease. We have to be aware of the so-called angina equivalents, and these are discomfort limited to the areas that are ordinarily sites of secondary radiation, such as the ulnar aspect of the left arm and forearm, lower jaw, teeth, the neck, or shoulders, and the development of gas and belching, nausea, and dizziness and diaphoresis. This is a picture of patients presenting with typical chest discomfort of coronary artery disease. You see over here somebody who is assuming the so-called divine sign, okay? A clenched fist placed over the sternal area. And over here is somebody who is diaphoretic. I would guess that probably he is having some cold sweats because of an acute coronary syndrome. This is an illustration of the differential diagnosis of chest pain according to location where the pain starts. So commonly for patients with coronary artery disease, the area over here, the sternal area, is the most common area of the most intense pain. But take note that this could radiate to the retrosternal area, interscapular area, to the arms, all right, lower extremities, lower anterior chest, and your epigastric area, okay? Take note, however, that the retrosternal, okay, interscapular, arms, okay, are commonly that of radiation of ischemic pain of coronary artery disease, okay? Here again, take note, retrosternal, myocardial ischemia, interscapular, myocardial ischemia. If it were on the right lower or left lower anterior chest, probably these are some other areas presenting with the disorder, but not necessarily that of the heart. Now, question, does the patient choose to avoid certain positions to reduce or eliminate discomfort? Again, this is just to illustrate somebody, a patient with chest discomfort, clenching his chest, right? The area of much discomfort is over the sternal or left anterior chest. This is a patient who assumes an upright position, okay? And patients with acute pericarditis usually get some symptom relief by assuming such position. It's upright. Okay. So again, in patients with acute pericarditis, the pain is characterized as being sharper and more left-sided than central. This is usually aggravated by breathing, turning in the bed, swallowing, or twisting. And take note, it is relieved or lessened rather when the patient sits up or leans forward. Aortic dissection could be a potentially catastrophic entity, and this is characterized by sudden onset, quite severe or very severe for that matter. It is persistent and usually radiates to the back and into the lumbar area. While costochondritis or myositis are associated with both local and costochondral or muscle terminus aggravated by motion or coughing. Your-Tight syndrome is a localized swelling of the costochondral or costosternal joints, and these are non-cardiac in nature. What about the relief of pain? If it were that your chest pain or the pain of your patient is relieved by rest or nitroglycerin, then the association of angina pectoris to this particular symptom is very, very close. So nitroglycerin or rest, more likely this is coronary in nature. What about cyanosis? Cyanosis could be both a symptom and a sign. You may have to distinguish whether your cyanosis is central or peripheral, right? And your central cyanosis is due to decrease in arterial oxygen saturation, due to right to left shunting of blood or impaired pulmonary function. Usually apparent at the mean capillary concentration of 4 grams per deciliter of reduced hemoglobin or 0.5 gram per deciliter of methemoglobin. This usually results to a low saturation, oxygen saturation of less than 85%. If it were peripheral cyanosis, this is due to secondary or because of cutaneous vasoconstriction due to low cardiac output or exposure to cold. Now, these are pictures of patients with central cyanosis. Normally, the lips are pink, right? And so with the tongue. But over here, what you see are bluish discoloration of both the upper and lower lips as well as the tongue. Okay? These are digits of patients exposed to extreme cold, for instance, and you see the digits, the tips of your digits becoming bluish in color. And this is an example of patients with some form of peripheral cyanosis. Differential cyanosis is an interesting entity. This is a picture of one with such differential cyanosis. This is nothing but the lower extremity digits are much more cyanosed compared to that of the upper extremity digits. Okay, so in patients with PDA or patent ductus arteriosus, one of the complications of this originally left to right shunt is that of pulmonary hypertension. And once significant pulmonary hypertension has set in, then the shunt becomes right to left with the more desaturated blood being shunted to the lower extremities. That's why you have more cyanosis on the lower digits than on the upper extremity digits. Okay, so interesting, or differential cyanosis. Now, what about the onset? If it were that the patient's cyanosis had started at early infancy, then you consider congenital heart disease with right to left shunting, okay? Or some blood abnormality such as hereditary methemoglobinemia. If it were that the onset of cyanosis occurred between age 3, then you could attribute this to possible spontaneous closure of PDA in the presence of right-sided obstructive cardiac anomaly. For instance, in patients with pulmonary atresia, these very young patients survive on the presence of a patent ductus to provide some pulmonary flow. But once your PDA closes, then these patients develop progressive cyanosis at this particular age. Okay? At age 6 or later, you might be developing progressive right ventricular outflow tract obstruction in patients with ventricular septal defect. In the ages 5 to 20, these are seen in patients with original left-right shunting, such as ASD, VSD, or PDA. And once they have reached some ages 5 to 12, you may already have developed pulmonary hypertension and secondary reversal of shunt, meaning right to left shunting. So these patients become cyanosed. What about syncope? Syncope is defined as loss of consciousness as a result of reduced perfusion of the brain. Okay? And it could be because of cardiac etiology or cardiac syncope. It is usually rapid in onset without aura and usually not associated with some convulsive movements, and consciousness is regained promptly. Okay? So these are some clues looking at the history, right, to elucidate the cause of syncope. Just some example. If it were because of drugs, then these patients could develop orthostatic hypotension, okay? If your patient is on antihypertensive, for instance, quite commonly potent vasodilators, alpha blockers, for instance, and it could be because of some metabolic problems such as hypoglycemia from, for example, excessive or excess insulin injection. If it were because of severe pain or emotional stress, then it is usually vasovagal in nature, right? If it were triggered by head movement or of the neck, this could be because of carotid sinus hypersensitivity. If it were because of exertion, this could be due to obstruction to left ventricular outflow, such as patients, for instance, with aortic stenosis. Motion of the upper extremities could lessen cerebral flow due to the phenomenon of the so-called subclavian steal, right? If it were sudden, then these are the possible entities, right? If it were gradual, this could be due to hyperventilation or hypoglycemia. Position at onset, okay? This could be because of orthostatic hypotension if it were due to rising. Very good example of this are patients, for instance, with prostate enlargement. They're placed on alpha blocker, and on rising early morning, they could just suddenly develop dizziness, no, or even fall because of the medication. They develop some form of syncope. For long-standing, commonly seen in patients with military who are military trainees, these are usually vasovagal, right? And some aspect about post-syncopal clearing of sensation, no? If it were slowed, it could be neurologic. If it were rapid, then other causes, right? So next symptom is that of palpitation. This is nothing but an unpleasant awareness of the forceful or rapid beating of the heart, okay? Edema is another symptom or sign. If you take note of the edema of the legs that is most pronounced in the evening, this is usually due to a failing left ventricle or congestive heart failure, or localized on the extremities such as your bilateral chronic venous insufficiency. And other than the edema, there might be an associated weight gain of at least 7 to 10 pounds. If ascites precedes edema, then this could be because of liver cirrhosis. But otherwise, if the ascites follows edema, then this is more likely due to either cardiac or renal disease. Nocturia is a common early complaint in patients with heart failure as well, right? Fatigue is quite non-specific, but fatigue could also due to heart failure, or could be because of drugs such as beta blockers for that matter. What about cough? So you look at the characteristic of the sputum, right? If it were pink, frothy, this could be due to pulmonary edema. If it were clear, white, or mucoid, this could be viral, right? If it were thick, yellowish, then this could be infectious in nature. Rusty sputum is characteristic of pneumococcal pneumonia. And still quite common among our population is that of tuberculosis, if it were blood streak sputum rather, no? Other entities that could bring about blood streak sputum are bronchiectasis, carcinoma, or pulmonary infarction, okay? So hemoptysis is production of blood, either strict or grossly. Again, quite common among our patients with pulmonary tuberculosis. Now, these are the different methods of assessing the so-called functional capacity. No? The so-called New York Heart Association Functional Classification, or fondly called NYHA, So NIHA stands for New York Heart Association classification. There is a counterpart in Canada, your Canadian Cardiovascular Society functional class. And these are the specific activities that the patient may do or may be able to do based on the reference here is what they could achieve in, for instance, the treadmill. Just to elucidate, if you have a class 1 patient, these are patients with cardiac disease, but without resulting limitation of physical activity, right? Ordinary physical activity does not cause undue fatigue, palpitation, dyspnea, or angina, okay? Very good example are, for instance, patients who could play basketball, but unknowingly they have heart disease, right? But over here is the extreme or class 4 patients. These are patients with cardiac disease resulting in inability to carry on any physical activity without discomfort. So these are the patients who are just chair bound or bed bound, no? And your 2 and 3 are in betweens, no? Your 2 are patients with cardiac disease resulting in slight limitation of physical activity, right? While 3 patients, functional class 3, are patients with cardiac diseases resulting in marked limitation of physical activity. If you go over the description of the Canadian Cardiovascular Society here, they're quite, to some degree, similar to your NIHA, okay? And over here are some of the physical activities that usually trigger symptoms. But let me just comment that we're more familiar and we're more frequently using the NIHA classification. And I repeat, NIHA stands for New York Heart Association Functional Classification for patients with heart diseases, right? So that ends my lecture for this morning, and I thank you for your attention.